So making America healthier for all, what each of us can do. So I want to begin by us thinking about what are some of the challenges we face in the United States. We do face many, but in terms of health, one of the most striking challenges is, according to the World Bank, the United States spends annually half of the money spent on medical care in the world. We are less than 6% of the world's population, consume one half of its medical resources, and rank near the bottom of the industrialized world on health, and we are losing ground over time. So if you look in 2014, the United States ranked 35th in the world on life expectancy, down from 11th in 1980. The US ranked behind countries like South Korea, Greece, Cyprus, Cuba, and Lebanon have longer life expectancy than the US does. And I'm going to talk about social inequalities in health in a minute. It's not just the minorities are doing badly. In 2014, if white America were a country, it would rank 34th in the world on life expectancy, and black America would rank 96th. And then there are these large gaps in health by race, socioeconomic status, place, and so forth. But I think we must begin the conversation by clearly acknowledging that all Americans are far less healthy than we could or should be, and the Sicker Lives volume from the National Academy of Medicine about 3 or 4 years ago made that point powerfully. And to understand these inequalities, we need to begin first by thinking of socioeconomic inequalities. I'm a sociologist, and I learned that socioeconomic status measured by income, education, occupational status predicts everything in society. Every desirable good and resource in society is stratified by socioeconomic status. And I want to give you an example of one of them that we might not have thought about, the SAT test, the Scholastic Aptitude Test, that many are calling the Student Affluence Test, because of the powerful relationship between SAT scores and socioeconomic status. So here is national data for the United States in 2014, persons taking the SAT test by family income, and you see this graded straight line relationship that every higher level of family income from less than $20,000 a year to over $200,000 a year is associated with a higher score on the SAT test. It raises profound questions of what does the test really capture, what does it measure, and how, as a society committed to equity, we really should use it. But what's true for SAT scores is also true for health status. This is work we did using the panel study of income dynamics with very rich assessment of economic status over time, looking at the relative risk of all-cause mortality by income level. And you can see, compared to persons in the highest income category of $115,000 or more, every higher level of household income is associated with, in fact, lower risk, overall risk of mortality. And not surprisingly, if income and education pattern so powerfully with the distribution of health in the United States, and by the way, as I'll show you in more detail in a minute, but let me tell you from now, we focus as a society on racial ethnic inequality in health. I mean, the government reports routinely report data by race. For most health outcomes in national data, the gaps in socioeconomic status are larger than the gaps in health by race. So it's really, really an intriguing sociology of knowledge question why we only focus on racial inequalities where the socioeconomic gaps are much larger. But there are large differences by race, ethnicity in socioeconomic status. Here's the latest national data we have on income, and I'm just translating it in a way that you can't miss the point. Standardizing the income for every dollar of income whites have. Asian households in the United States have $1.23. 70% of Asians are immigrant. Asians have markedly the highest levels of education in the United States. Most Asian groups have the rate of college completion is 2 to 3 times that of whites in the US. And Asians also have more persons contributing to household income, more persons employed in the household. So if I use the per capita income measure, whites would have the highest level of per capita income. But if you look at the historically disadvantaged groups, for every dollar of income in 2015 that whites had, Latinos had 72 cents, Native Americans 62 cents, and African Americans 59 cents. What's stunning about the 59 cents figure is that it's identical to the racial gap in income in 1978. In 1978, blacks in the United States earned 59 cents for every dollar of income whites earned. And I picked 78 because that's the peak year of the gain as a result of the Great Society and the civil rights activities of the 1960s and early 70s. Because throughout the 80s, for example, blacks, the income gap was lower than the 59 cents level. So most of my students think we've made a lot more progress than that. And these data on racial differences in income dramatically understate racial differences in economic circumstances. We need to look at wealth that captures that, because wealth gives us the cushion, the economic reserves that households have to cushion shortfalls of income. And the most recent national data we have on wealth, for every dollar of wealth that white households have, black households have 6 pennies and Latino households have 7 pennies. The racial gaps in wealth today are larger than they were when President Obama first took office, because during the economic downturn and the housing crisis, black and Latino households had disproportionate losses of both home ownership and home equity. So not surprisingly then, there are large racial differences in health in the United States. And there are two patterns that are evident. For groups that have been here for a long time, characterized by economic exploitation, social marginalization, and stigmatization, blacks are African Americans, Native Americans, and Native Hawaiians and other Pacific Islanders. Those 3 groups, we have more data on blacks, but the data for the other 2 groups, where it's available, shows exactly the same pattern, are doing markedly worse. On the other hand, immigrants tend to have better health than the native-born. In fact, immigrants of each race have better health than the native-born population of their own race. If we look at readily available national data on infant mortality or overall mortality, white immigrants have better health than whites born in the US. Black immigrants have better health than blacks born in the US. Asian immigrants have better health than Asians born in the US. Latino immigrants have better health than Latinos born in the United States. Across the board, there is a healthy immigrant effect. The bad news is the longer immigrants remain in the United States, the worse their health becomes. It's as if the health data is saying there's something about our way of life that's dangerous to your health. And so, looking at one example, infant mortality rates in the United States by race ethnicity, you can see the towering excess rates 2012 for African Americans, and you see Native Americans also have a higher rate, whereas Latinos and Asians have rates that are much more comparable. Again, if we disaggregated the Latino data by nativity, you would see quite divergence within the Latino data, and paying attention to that is a crucial issue. I just want to say in passing, I don't have time to give you examples from multiple other countries, that the patterns in the United States are not unique. They are identical to the global patterns you see. So just picked one example. This is the UK. Infant mortality by ethnicity, and you can see whites have relatively low rates, and the 2 black groups, blacks from the Caribbean and blacks from Africa, and Pakistanis have markedly higher rates. Indians have lower rates, much better off in socioeconomic status, and so forth. Minorities also get sick at younger ages in US data, have more severe illness, and die sooner than whites. One of the most striking patterns, Arlene Geronimus is credited with the term weathering. The notion of weathering, imagine a drop of water falling from the rooftop of this building to the concrete sidewalk below. If a few drops of water fell today, there'd be no problem. But if there is a constant drip, drip, drip of water, day in, day out, week in, week out, month in, month out, the concrete below becomes weathered. It becomes eroded from the constant onslaught of adversity. The same is true for minorities in the United States. For minorities, chronological age captures not only how long they have lived, but how long they've been exposed to bad environmental conditions and how physiologically compromised they have become as a result of this exposure. And so we have a lot of evidence, and some scholars call it accelerated aging, some call it premature aging. Arlene Geronimus calls it weathering, that minorities are literally aging more rapidly than whites in the United States. In the interest of time, I'm just going to show you one study, and just using telomere length as the measure of aging, and she studied African American and white women at the same middle age, at the same chronological age, but the African American women, based on telomere length, were 7.5 years older biologically. And there are lots of other evidence that illustrates that with multiple other indicators of aging or overall health status. We also have this phenomenon in the United States of the persistence of racial ethnic disparities over time. Here's one example with good news and bad news. Life expectancy for blacks and whites, the only two groups we have data going back from 1950 to 2010. There's good news here. There was an 8-year gap in life expectancy in 1950. There's a 4-year gap in 2010, so we've cut the absolute gap by half. And you can see other good news is for both blacks and whites. There's a steady increase in life expectancy over time. At the same time, a 4-year gap in life expectancy is quite large. If we froze the life expectancy of whites and had the life expectancy of African Americans increase at the average rate at which life expectancy has increased nationally in the last decade, it would take about 30 years to close that 4-year gap. In fact, you can see that in the data. Look at 1950, the life expectancy of whites at birth, 69.1 years. How long did it take for African Americans to catch up to the health that whites had in 1950? 1990, African Americans had a life expectancy of 69.1 years. 40 years later, in all the comparisons in this table, there's a 30 to 40-year gap in health between two groups living in the same society. When I started my career, most researchers believed that these racial inequalities in health were simply a function of these striking differences in socioeconomic status, in income, in education, occupational status, in wealth. We now know that life is more complicated. And to illustrate that, I'm going to show you life expectancy data nationally for the United States at age 25. There's a 5-year gap. The average 25-year-old white person will live 5 years longer than the average 25-year-old African American. If you look at the variations within the white population by education, same is true for income. I'll show you the education data in interest of time. You can see whites with a college degree live 6.4 years longer on average than whites with less than high school completion. Again, bigger than the black-white gap. And if we look within African Americans, you see a 5.3-year difference between the high and low education groups. Again, the socioeconomic inequalities by income or education are larger than the racial gap. At the same time, at every level of education, there still is a persistent residual effect of race. So white high school dropouts live 3.1 years longer than black high school dropouts, and the differences are even larger among the college graduates. And in fact, if you look at the data very carefully, you see this stunning, remember this is national data for the United States. And what you can see here is that the best off African Americans, those with a college degree or more education, have lower life expectancy than whites who have completed high school. This data powerfully tells us there's something profound about economic status that drives health in the United States, but there's something else about race that continues to matter profoundly even after we've taken economic status into account. What exactly is it about race? There's data suggests there are 4 reasons. I don't have time to elaborate on all 4 today, but I'll mention them and look a little more closely at racism. One is health is affected not just by your current economic circumstances, but by all that you have been exposed to over your life course. In fact, we now have data what you've been exposed to in your mother's womb and what you've been exposed to even before your mother became pregnant affects your health, and there's good scientific data on this as well. So you have to take a life course perspective. The college-educated African Americans today are more likely to have been born poor, more likely to have been born low birth weight, more likely to experience deficits in access to nutrition and medical care and higher levels of adversity, so a range of factors that shape your current circumstances. 2, all indicators of socioeconomic status are not equivalent across race. What do we mean by that? We mean in national data, for example, compared to whites, blacks and Hispanics receive less income at the same levels of education, have less wealth at equivalent levels of income. And this last one is a dramatic example of how life is not fair. The places where African Americans, Latinos, and Native Americans live are much worse. Goods and services are worse, but they have higher costs. Well established in economic studies that minorities pay more per square foot for rent in disadvantaged inner city neighborhoods than in suburban neighborhoods, more for groceries, more for insurance. You can go down the list. The dollar doesn't stretch as far. And thirdly, personal experiences of discrimination and institutional racism continues to affect health. I'll elaborate on that. And minorities in some of my work and the work of others indicates, not only have higher levels of stress, but they also have greater clustering of stressors. So if they have one, they're more likely to have multiple. So let's talk a little bit about discrimination and racism and the ways in which it has health consequences. We need to distinguish between individual and institutional racism. This is a study done by researchers at Portland State University in the great city of Portland. I'm not picking on Portland in any way. They took 3 black males and 3 white males, dressed them similarly, and sent them at different intersections to cross the street. And the question was, does your race determine how long you have to wait to cross the street? Multiple cars were twice as likely to pass the black person waiting to cross the street compared to the white person, and on average, African Americans had to wait 32% longer to cross the street. That's individual discrimination. It's reflecting what individual drivers decided to do. But let me give an example of institutional discrimination also linked to waiting. In the 2012 presidential election, African Americans and other minorities waited longer to vote. Now, none of this reflected individual discrimination on the part of precinct workers. In fact, it reflected powerfully where you went to vote and the resources through institutional policies that were available, the budget allocation, the space constraints, the local administrative procedures that determine how many potential voters were served by a given precinct. It was all institutional mechanisms, but it nonetheless led to unequal weighting in order to do something as simple as voting. We cannot understand inequality in the United States if we don't understand the powerful institutional mechanisms that have produced it. Residential segregation by race is a striking legacy of racism and institutional mechanism, as well as the forced removal and relocation of indigenous peoples that has led to very different outcomes in the United States. Because where you live in the US determines powerfully, for most Americans, where you go to school and the quality of education you have access to and your trajectory of socioeconomic opportunities. It determines access to jobs. It determines the quality of housing, the quality of neighborhood environments, whether it's easy or difficult to live a healthy life in terms of access to food or access to safe places to exercise or nearby nature. It determines exposure to chemical substances, and it determines even the quality of primary care and access to high quality care is all shaped by place. So when segregation and Native American reservations isolate people from opportunity, there are in fact profound effects. So as part of the Robert Wood Johnson Foundation's commission to build a healthy America that I served as a staff director for, we created maps, and Steve Wolf did these maps from us for Virginia Commonwealth University of different cities, and I picked the map of New Orleans. Here is metropolitan New Orleans, and just from one neighborhood to another, there's a 25-year difference in life expectancy just linked to where exactly do you live. 2 of America's most eminent sociologists, William Julius Wilson and Robert Sampson, studying the 171 largest cities in the United States, has said there's not even one city where whites live in equal conditions to blacks, and that the worst urban context in which whites reside is considerably better than the average context of black communities. John Sell, a historian at Duke University, wrote a book on the origins of segregation in the US South and South Africa, showed that South Africans, the framers of apartheid, looked across the Atlantic and saw what we had done in the late 19th and early 20th century and said, brilliant, we love it, we will do it because it's a mechanism to enforce inequality in South Africa. He argued that residential segregation by race in America was one of the single most successful domestic policies of the 20th century. It's beneath the radar screen. No one is talking about it, but it is driving inequalities. How powerfully is it driving inequalities? David Cutler, an economist at Harvard University, did a national study looking at blacks and whites using fancy econometric models I cannot even fully describe. He shows statistically, though, that if you could eliminate segregation in America, you would completely erase black-white differences in income, in education, and in unemployment, and reduce black-white differences in single motherhood by 2/3. All of that driven by the opportunities linked to place. So the racial differences in health are not random events. They're not acts of God. It didn't just happen and come out of thin air. They actually reflect the successful implementation of social policy. Racism has in fact produced a truly rigged system that produces and sustains inequality in the United States. And I want to talk about how some of this plays out, other dimensions. So we talk about institutional racism. What about the interpersonal dimensions, and how does that have consequences for health? Experiences of discrimination could be, for those experiences that individuals are aware, are a type of stressful life experience. This is the everyday discrimination scale that I developed. It doesn't capture all of discrimination, but it captures the subtle, day-to-day chronic indignities that individuals experience. Being treated with less courtesy and less respect and receiving poorer service than others, and if people acting as if they are afraid of you or as if you are not smart or if they think you are dishonest. Little things. Just to illustrate the power of the research on discrimination, by the way, it's gone global. These processes occur across multiple other societies as well, and race is not the only basis of discrimination, although it's a very powerful one in racialized societies. I want to illustrate that by the work of one researcher, Dr. Tanya Lewis, who was at Yale University at the time she did this work, currently at Emory University. Every line in this study represents a different peer-reviewed published paper. In each paper, she's looking at this everyday discrimination as the exposure and a different health outcome. So higher levels of everyday discrimination associated with high levels of inflammation, associated with more rapid developments of coronary heart disease as measured by coronary artery calcification, is associated with high levels of systolic and diastolic blood pressure. Pregnant women who report everyday discrimination give birth to low birth weight infants. A study of the elderly followed over time. Everyday discrimination predicts more rapid declines in cognitive function over time. A community sample, higher levels of everyday discrimination predicts poorer sleep. A study of adults followed over time. Everyday discrimination is an independent predictor of mortality, leads to premature death. And a study of African American and white women, higher levels of everyday discrimination, unrelated to waist-hip ratio, unrelated to waist circumference. But the real bad kind of abdominal fat that you need to use imaging data to get at is the visceral fat, to separate it from the deep fat in between your body organs, as you know. And high levels of everyday discrimination, unrelated to subcutaneous fat, but predicted high levels of visceral fat. So exactly the bad fat that leads to a broad range of outcomes. Let me also give you another study from discrimination, the work of Gene Brody in Atlanta. He's been studying a cohort of African American teenagers, measured discrimination at 3 times at age 16, 17, and 18, and is looking at a number of indicators of biological functioning at age 20. And at age 20, this is not age 40 or age 60, at age 20, those teens who reported high levels of racial discrimination consistently while they were teenagers, we can see biological dysregulation in stress hormones and systolic blood pressure and BMI differences at age 20. There are also studies showing epigenetic aging at age 22 in these teenagers linked to high levels of discrimination in their teen years. So these effects are being evident very early in life. What can we do about all of these challenges? The first thing we need to do is to provide high-quality care to every client. And somebody says, did you come all the way from Boston to tell us to do this? That is such a no-brainer. On the other hand, as someone who served on the Institute of Medicine's Unequal Treatment Report Committee, National Academy of Medicine, we know that this is, in fact, very difficult to do. Just to give you an example, you are probably well aware, but for those of you who don't, I'll give you one example of the studies. Dr. Todd was an emergency room physician at UCLA and asked a simple question. When a patient comes into the UCLA emergency department with a long bone fracture, broken bone in the arm or leg, does the patient's ethnicity make a difference with whether the patient gets pain medication? And reviewed the charts for an entire year and found that 55% of Latinos with a long bone fracture had received no pain medication compared to 26% of non-Hispanic whites. Dr. Todd was a good researcher. He said, confounding is something else. So statistically adjusted for the age of the patient, their gender, whether they got injured on the job or not, what time they showed up in the ER, how long they spent in the ER, whether they spoke English or Spanish, the severity of the fracture. And statistically, after you adjusted for everything else, it just made a difference larger, and Latinos were 7.5 times less likely to get pain medication. Dr. Todd moved from UCLA to Emory University in Atlanta, repeated the same study, looking at emergency rooms in Atlanta with black and white patients, found exactly the same thing. A black patient with a broken bone in the arm or legs shows up to an emergency room, is less likely to get pain medication compared to a white patient. How on earth do we make sense of that? How is it possible that the best trained medical workforce in the world, who works up every day and goes to work intending to do their best for all of their patients, can nonetheless produce a pattern of care that appears to be so discriminatory? And please don't focus on pain medication, because that's just one example. This has been best documented in the area of cardiovascular disease. At the time of the IOM report, there were nearly 200 published peer-reviewed studies. There are many more. The patterns persist. We even know more about it now than then. Our best explanation was implicit bias, or unconscious, unthinking discrimination. And what the research shows is that if you hold a negative stereotype about a group and meet someone from that group, without your conscious awareness, with no intentions on your part, you will treat that person differently. It's an automatic process. It's an unconscious process. I usually like to tell my students that I'm a prejudiced person. I'm a prejudiced person because I like to think of myself as a normal human being. And if you are a normal human being, you are most likely prejudiced. I didn't say you were racially prejudiced, because race is only one dimension. This is really not about Americans. This is not just about race. This is about how all human beings process information. Every society has in-groups and out-groups, and everyone is socialized to think of some groups more positively than others. So if you have negative stereotypes about gay people, about fat people, about poor people, about women, about old people, these same processes operate. And that's why all of us have to realize that, yes, it could be me. Because if you set yourself up for failure if you say, I would never do that, because I think of everyone equally. Lisa Cooper at Johns Hopkins has shown that these processes affect not only the actual treatment, but even the quality of the provider-patient relationship. In this study, they videotape providers who worked in safety net clinics in the greater Baltimore area. So these are people who cared enough to serve the most vulnerable, and documented based both on their analysis of the videotapes and on patient reports, there were systematic differences in the quality of doctor-patient provider. Where do all of these negative stereotypes come from? They are deeply embedded in our culture. Researchers have produced a database of American culture. They've put in this database the books, magazine articles, newspaper articles the average college-educated American would read over their lifetime. The beauty about this, I can now look in this database of American culture and say, when the word black occurs, what tends to co-occur with it? It's poor, and then violent, and religious, and lazy, and cheerful, and dangerous. When white occurs, wealthy, progressive, conventional, stubborn, successful, educated. For the fun of it, when female occurs, distant, warm, gentle, passive, male, dominant, leader, logical, strong. Here are the 10 most common stereotypes for blacks and whites in American culture. This has profound implication for a lot of the social challenges we face in American society. So when a police officer sees a young black male and overreacts because he sees him as violent and dangerous, we are not necessarily dealing with a inherently bad cop. We are simply dealing with a normal American who is reflecting what is deeply embedded in his subconscious as a result of being raised in this society. And we need to think of what can we do as a society to change the narrative and to change the deeply embedded messages that individuals are getting as a result of being socialized in this society. The good news is Diana Burgess and colleagues show there's a lot that we can do in terms of evidence points to strategies that we can implement to reduce unconscious bias. And I usually like to point people to the Devine solution. Professor Patricia Devine at the University of Wisconsin-Madison has shown there are a range of strategies that if we put them together, like stereotype replacement and counter-stereotype imaging and individuation. Individuation is a big one. All of us naturally use social categorization. We put things into categories to deal with all of the complex cognitive information we are bombarded with each day. Individuation means I will resist the natural tendency to put things into categories and try to see each person as an individual, as opposed to the three things we notice about someone when we meet them in America is their race, their age, and their gender. So to focus not on those three characteristics, but on who that individual person is. The implicit association test is one powerful way that we can see where we are. What else do we need to do? We need care that addresses the social context. As the World Health Organization says, what do we accomplish if all we do is treat illness and send people back to live in the same conditions that made them sick in the first place? Which means we need to be asking a set of new questions about how do we identify the non-medical needs that all patients have, and how do we connect patients to resources and services that are not inherently medical but are necessary for their overall development and care. How can we connect and collaborate with other sectors in our communities to meet the needs of our communities and our patients. The Medical Legal Partnership, born in the Boston Medical Center, is an example of the kind of program that we need more of, although it now exists in over 200 medical centers. The point is, it's linking attorneys as part of the healthcare team can take a much more comprehensive approach to meeting patients' needs. Because a child with asthma in a moldy apartment will not breathe symptom-free regardless of how much medication you give that patient, if that patient goes back to live in the same conditions that made him or her sick in the first place. Health Leads, also born at the Boston Medical Center, is another example. This one now uses college student, undergraduate volunteers to work as part of the healthcare team to identify the needs and to meet the needs that patients have much more broadly. This is a health vital signs checklist from the Health Leads program, deals with issues in terms of housing, in terms of nutrition, in terms of utility, in terms of access to employment opportunities, and so on. There are multiple wonderful examples, including the Oregon Medicaid program that has been collaborating with healthcare and social service providers to provide more seamless continuity of care to patients, or in Minneapolis, the Hennepin County Accountable Care Organization linking Medicare health services to county-provided social services. Again, a comprehensive approach. But we also need to move further upstream, and I'm going to give you two examples of moving further upstream. One is improving early childhood and early childhood opportunities. The Abecedarian Project in Chapel Hill, North Carolina, shows us how powerfully, by providing high-quality care birth through age 5, they've now had the kids were randomized to receive this, so they can now look in their mid-30s and find dramatic differences in risk factors for cardiovascular disease and metabolic disease just linked to what happened birth through 5. So here's an example of the dramatic difference in systolic blood pressure in the mid-30s linked to what happened from birth through 5 in the treatment group compared to the control group. One of the challenges we face is the high child poverty rate in the United States. We rank 34th in the world on child poverty. And what I want to illustrate, this is not inevitable. There are many countries in society that have markedly higher child poverty rates before taxes and transfers than the US does. And you can see in Ireland, it's a 42% of children are in poverty before taxes and transfers. That means the economy in Ireland produces a 42% rate. Taxes and transfers refer to policy decisions the societies makes to put supports in place. And after those decisions are made in Ireland, the poverty rate for children is cut from 42% to 8%. In the US, it's cut from 24% to 23%. We're doing nothing to support and provide for our children compared to what other societies are doing. If you haven't seen this, this is a wonderful resource, The Raising of America, produced by the same persons who did Unnatural Causes of Inequality Making Us Sick. It's a wonderful resource. You can find it online that really talks about the opportunities in the area of early childhood resources. We also need to move further upstream by thinking of what can we do to change the living conditions of individuals. The Move Into Opportunity program gives us high quality evidence of taking public housing residents and randomly moving some to lower poverty neighborhoods. 10 to 15 years later, those that were moved, no health intervention, you just moved them to higher quality neighborhoods, lower levels of obesity, lower levels of severe obesity, and lower diabetes risk. And final example I want to give you is purpose-built communities. A first purpose-built community site was in East Lake, Atlanta. And what characterizes the approach of purpose-built community is that it's trying to address all of the social challenges poor communities face simultaneously. And I want to show you how dramatic their results have been. So come with me to East Lake, Atlanta in 1995. It was an African-American public housing project with a $35 million a year drug trade. 90% of the residents were victims of a felony each year. 13% of adults were employed. Most were on welfare. It was one of the worst performing schools in Georgia. I visited purpose-built East Lake last year. There's been a 73% reduction in crime and a 90% reduction in violent crime, high-quality private managed housing. Every able-bodied person is employed, and the school is one of the best performing schools in the state of Georgia. It shows that it can be done. And by the way, Purpose-Built Communities is providing free technical assistance to any community in the United States who wants to implement their model. Finally, before I stop, given the moment we are in, I have to talk about the social safety net and their current proposals in Washington, D.C. that would dismantle the social safety net in powerful ways. I want to remind you that we actually know what would happen when we dismantle the social safety net. We just need to go down memory lane a little bit. The 1981 Omnibus Reconciliation Act, a bill passed in the Reagan administration, savaged the social safety net in the United States. 500,000 people lost welfare. 1 million people were dropped from the food stamp program. 600,000 people lost Medicaid coverage. Children were 40% of all poor, but only 1/3 of poor children were covered by Medicaid after this act was passed. 250 healthcare centers closed across the United States, and 1 million children lost reduced price school meals. Medicare deductibles increased dramatically for the elderly, and there were consequences for the health of the population. Women who did not receive prenatal care had more health problems. OB visits at neighborhood health centers declined. There was a 143% increase in the rate of anemia. There was an increase in the incidence of low birth weight nationally in the United States. In 20 states in poor population, there were increases in infant mortality. In terms of America's children, studies in Chicago and Minneapolis and Boston showed an increase in preventable childhood diseases in poor populations across the country. For example, in 1984, the incidence of measles in the United States had increased for the first time since 1963. Among adults who were dropped from the Medicaid program, we saw an impact on chronic disease, like an increase in blood pressure among patients in California dropped from the Medicaid program. So what I'm saying is we absolutely know what happens when the safety net is hurt. And so we need to think of what can we do as individual citizens and as a group to advocate to keep and strengthen the very fragile safety net that is likely to become even more strained if some of the budget proposals are implemented. A resource I want you to have is the Robert Wood Johnson Foundation's Commission to Build a Healthy America. Its report is on the RWJF website. It talks in much more detail than I've been able to talk about early childhood, about how we can build more health into healthcare with examples of even more programs than I've given you that are working across the country to make a difference. And I leave you with two powerful quotations. One from Dr. Martin Luther King. True compassion is more than flinging a coin to a beggar. It understands that an edifice which produces beggars needs restructuring. You are working on the front lines of helping individuals in deep need, but we also need to go upstream and deal with the edifices that are producing the problems in the first place. And finally, this is a quotation I used in my recent TED Talk as well, from Robert F. Kennedy. Each time a man, and I would add a woman or woman, stands up for an ideal, or acts to improve the lot of others, or strikes out against injustice, he sends forth a tiny ripple of hope. And those ripples can build a current which can sweep down the mightiest walls of oppression and resistance. My journey here to Portland would be worth it if each one of you today made a commitment that you will be a ripple of hope, right where you are every day, to make a difference, and together we can sweep down the mightiest walls of oppression and resistance. Thank you.